existing health data, patient-reported outcomes, and PBRN research. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice-Based Research Network Initiative at the Agency for Healthcare Research and Quality, will introduce today's presenters. Please note that we will have a final Q&A with all presenters at the conclusion of the webinar. This webinar is still pending approval from the American Academy of Family Physicians for CME credit, but we will be offering CME certificates of participation once approved. At the end of the webinar, I will explain how to obtain these CME certificates of participation. After the webinar, a copy of the presentation slides will be emailed to all participants. The recording of today's webinar will be posted to YouTube in the coming weeks. We will notify today's participants when the video becomes available. If at any point during today's presentation you have trouble hearing our presenters, please try hanging up the phone or headset and dialing back into the webinar. You may submit a question at any time throughout the presentation. To submit a question, type a question under the Questions section on your GoToWebinar control panel and hit Send, as shown on the screen. During the Q&A session, as time allows, your questions will be read out loud and our presenters will respond. I will now turn the presentation over to Ms. Roper.
Thank you very much, Christina. So we're just tickled that Drs. Pace and Fox have been willing to give a presentation in response to demand from the PBRN community for contextual information with respect to how to use big data in quality improvement projects and the linkages of big data. Some of you will remember last year's NAPCRG PBRN meeting had a component about big data and the use of big data, which continues to be a very popular topic. So, and we are very grateful to Drs. Pace and Fox for clearing their schedule to record this CE Earning webinar today. And Dr. Pace is familiar to many of you as Professor of Family Medicine and the Green Edelman Chair for Practice-Based Research. He hails from the University of Colorado, Denver. Is Director of American Academy of Family Physicians National Resource Network, and has a long history with DARTNet institution, including being a Chief Executive Officer. Dr. Fox hails from a little further north of the country in latitude, but has same type of skill set and enthusiasm, both of these gentlemen do, for finding solutions for primary care, both for the providers and the patients. He is the director of the Upstate New York Practice-Based Research Network, UniNet, which is very keen on engagement of their patients. And he is also involved in one of our P30s, the Mosaic P30, headquartered in Kansas with networks around the country. So we're going to go through today. We have an intimate group of live participants, so to speak, on this Friday afternoon. After each presentation, we encourage you to pose questions using the question function, which Christina will put up on the screen for you. And we look forward to a lively conversation and both having answers coming from the dear doctors and questions that we will pose to generate a nice dialogue. And with that, I will turn it over to Dr. Wilson Pace.
Thank you, Rebecca. We'll just try to get some slides up here, and hopefully all that's working. So I really appreciate the chance to talk about some of the things that Chet and I have been working on over the last.
Dr. Pace, we can't hear you. Oh.
Can't hear me.
Oh, now we can. Okay, great. We lost you for a second.
Okay, I think I'm here. Am I there now? Okay.
Yes.
Yeah, okay. So I appreciate the chance to talk about this. First, my disclosures through the AAFP National Research Network as well as through DARTNet, I do have some research contracts and grants with industry. And through my advisor, I do have some stock in industry. We're not going to talk about off-label medications, at least I won't. And Chet, I'll do his too, since I'm doing the presentation right now. He has nothing to declare for investments, research grants, consulting arrangements or off-label medications. So really we want to talk about what access to existing electronic data offers PBRNs, and then demonstrate some of the methods that we've kind of worked on across different projects that I think have really advanced the way we can think about PBRN research. So one of the things that allows you to start doing early on, but even at the time you're conceptualizing a grant or application, is to start characterizing your patient population a lot better than we used to, and I'll show you some thoughts about that one. We're going to talk about some novel approaches to cluster randomization, and that's pretty a classic approach to many PBRN projects, is as we try to deal with projects that are much more QI oriented for a practice, we often have to randomize at the practice level, and there's some issues with kind of standard approaches that we can overcome if you have existing data. We'll talk about some things that I think are characteristics of PBRNs so we can get more complete outcomes. Chad will talk about that. Be able to assess side effects or negative impacts easier, perhaps, and others like that. Finally, we'll talk a little bit about, one thing on here, we'll talk about collecting data directly from providers and patients, another one of those sine qua nons of PBRNs, and temporal control. So try to cover a lot in, and it'll be a fast presentation for a lot of these areas. So this is just an example. This was a project that was posed to me from a cardiologist who really wanted to understand what's going on around atrial fibrillation and the current medications. There's new agents out there. They have kind of unclear indications of who should be on newer and older agents and what kind of data could come around from it. And so we quickly took a subset of our data set of about 850,000 patients, and we started to look through this. Do we find atrial fibrillation diagnoses enough to actually do any projects? Do we find them on warfarin and newer agents? Do we find them on both drugs? And the point was that out of this population, you do see these patients. They are being treated in primary care. The medications are coming through as being prescribed by the primary care physicians for these patients, and it was a study that could be done. She decided to go on and do some other things, but this is the kind of data that, from my perspective at least, that somebody had come to me previously and said, I want to study atrial fibrillation in primary care. I would say, yeah, probably can't do that. Don't even think about it. So, you can start to look at your population by age. Gender, obviously, a much better. You look about the percent of a condition within your study cohorts. You start to think about, you actually can look for observed complication rates based on diagnoses or lab values. And you actually have I have all different ways that I start to think about bringing practices or organizations into studies. I now look at the size of the population of the practice, understanding the underlying prevalence that I actually know for sure from the data I'm looking at, and I don't really start asking practices anymore, how many patients do you think you can get? You're pretty clear, you understand how many you can find from this kind of data, so it really changes, at least from my perspective, how I start approaching whether I can do a study or not, and I really start who I should let in. And if I have only so much money, do I really go to much bigger organizations? Can I let in small practices? And all of that kind of activities really allows you to get much more focused at that level when you're starting to look at the practices. Some pre-research use of data, I think you can actually, if you're into treatment activities or activities like that, you can actually start to look at prescribing practices before you actually get into research. You can look for illogical practices, things you may need to be aware of. We didn't do that quite as much as we probably should have for Chet's project, which he'll talk about in a second. But for instance, when we wrote the grant for Chet's project, we assumed that everybody was doing lots of creatinines just as a background effect of ordering lab tests, and we found out that that wasn't true in every practice. And after we actually got into the project, had to change some of what we did with the intervention with some practices because of that. So we could have, if we had looked a little closer at that point, that was 6 or 7 years ago now, we would have probably figured out a little different intervention at that time before we wrote the grant. And we'll talk about balancing interventional cohorts. So here's an example of some work that we've done around diabetes and looking at what is the initial medications, and here you can see what happens. I'm not going to try to go through it, but as you might imagine, metformin, which is this black line, shows up with low doses, but it's surprising that at around an A1C of about 10.5, insulin actually becomes the #1 drug started. as the initial drug in these patients. And if you're trying to do a study that's focused, I mean, without understanding the impact of insulin today within this group, you might really go in some different directions. This is what kind of pre-data from what Chet's grant kind of deals with, but as you might imagine, as creatinines go up, insulin just takes over. But you can kind of watch all these different drugs and where they come in and kind of get you some ideas of what you might want to think about. So this is a very different view of your population and your practices prior to starting a study than I think we've ever had before in the PBRN world. So really, today, as we go through it, it now allows you to guide the study question and make sure if we had done some of that work for Chet, we might have changed the study intervention slightly. We'll talk about guiding study methods to some degree, and we'll talk about that one. We talked already about site selection and assignment. So really having this data as you get started in the process of research, it just changes entirely the way I think about data these days. I think about researching things. One of the things we don't want to lose, and people that I think is important in our PBRN work, is that we actually have a close relationship with most of our sites that are sharing data, and we really are talking to the clinicians. We're often working on the ground level with them about how they're using their EHRs and the data they're collecting, and how they're using that data, feeding data back to them. So we don't want to lose that relationship that is a PBRN, and it requires a little more active data collection. It's not just using data mining. It really is using data to have an interactive conversation with your clinicians, and Chet will talk about that as well. One of the things that's very helpful where you can do that is having a point of care ability to feed data back at the point of care or near the point of care to explore decision making with clinicians. So Chet, I'll let you talk about your project, and then we'll go into some specifics from after that kind of quick overview.
Yeah, my study was a translating evidence into practice study. Actually came from the AHRQ concept of translating research into practice, but after working with practices for many years, they're scared of the word R a lot of times, the R word. So we changed it to translating evidence into practice, where it was a quality improvement kind of study. And a lot of what we do in translating evidence into practice is quality improvement research. It was very much a pragmatic clinical trial. And if you don't know, there are basically 4 principles of the pragmatic clinical trial. One is to select clinically relevant alternatives that you're comparing. 2 is to look at diverse study populations. 3, to recruit heterogeneous practice settings. And 4, to collect data on broad-based health outcomes. So really, the pragmatic or practical clinical trial is something, can it be generalizable, can it be used for health policy? I became interested in chronic kidney disease when the KDOQI guidelines first came out in about 2002, and found that I was not doing a very good job taking care of chronic kidney disease, and also that primary care interest was not that great. But DARTNet was sort of revolutionary in terms of being able to take what I was able to do in small pilot studies with like 4 practices or 6 practices, and see whether nationally we could improve outcomes in chronic kidney disease. And it was revolutionary in a couple ways. First, it was revolutionary in terms of being able to have a national scope for what we were trying to do, and to get large numbers of data that was already available. Now, the point of this is that the data is already available in EMR. So therefore, really, the research data is a byproduct of already existing clinical data. To give you a perspective on this, and it's also a lot less expensive from the funder's point of view to collect the data. And I do believe the reason I did get the grant from the NIH to do the study is because of the large amount of data and the diverse nature of the practices that we were there. The largest study in stage 3 and 4 chronic kidney disease is called the chronic renal insufficiency cohort, where they did the standard individualized recruitment and followed the cohort for a period of, it's now going on 13 years, and they're deciding whether whether they're going to continue. That cohort is 3,600 total patients, and it's the investment from NIH is $100 million to follow these 3,600 patients. We're using a cluster randomized approach with the idea is that the practice is the unit of randomization, and we even got into trouble with the idea that the practice is the unit of randomization and we had to change some of the randomization and when we did it in waves, because sometimes we need to organize to randomize at the organization level and not the practice level. But the study was originally designed for 40 practices, 20 in each arm, and tracking all the outcomes of the guidelines through the EHR. And ultimately, we did this as a mixed method study. So we had a qualitative and process evaluation, and then we had intermediate outcomes like change in blood pressure, use of ACE and ARBs, et cetera. And the harder clinical outcomes, we probably won't have enough time in the current study to complete. Our hard outcomes were going to be total mortality, progression to end-stage renal disease, or rapid progression of chronic kidney disease. With that, in the current study, we have 28,000 patients within the arms of the study. Next slide, please. The study objective is we're testing two approaches to improving care for stage 3 and 4 chronic kidney disease patients. When they hit stage 5, then that was sort of an outcome of the study. The control practices had point-of-care computer decision support alone for CKD patients. Now, the point-of-care computer decision support wasn't just for kidney disease alone. They already had a computer decision support system that worked on, they created a patient profile nightly for various things like cancer prevention, immunizations, other things, created a patient profile which doctors were using for diabetes, hypertension, and all other diseases. We added the chronic kidney disease decision support on top of the existing. Basically, you get a normalized data set that's pulled from multiple different EMRs. So no matter what the EMR, whether it's EMR Cerner or Allscripts or NextGen or Epic, it normalizes the data, then runs an evidence-based decision support algorithm, then gives the recommendations back to the practice. Now, this was designed to help the clinician at the point of care. This was not a population health tool or a registry tool, but we'll get into the importance of that in a moment. So we just did a single academic detailing session, the control practices, on what the guidelines, the evidence-based guidelines for chronic kidney disease, and the others, we did something that was based on TRANSLATE. TRANSLATE is an acronym that was a 9-point model for implementing the chronic care model, first done by Kevin Peterson at the University of Minnesota with success in diabetes, and I was transposing that to diabetes. Now, the TRANSLATE, each of those has it's an acronym. So the T is for target or goal setting, the R is for point of care decision support, the A is for administrative buy-in, that's resource allocation for the project, N is for network information systems or population health registries or tools, S is for site coordination at the staff level, L is for a local clinician champion, so do the doctors support it, is there physicians at the staff, A is for audit and feedback, which we give tools for, T is for promoting a team approach, and E is for education, which is training in all its forms. So it's sort of an operational way of doing the chronic care model, especially on creating prepared, proactive systems. That plus we did virtual practice facilitation. Because it was a national study, we couldn't do the practice facilitation on the ground in terms of the various places. We had practices from Iowa to Los Angeles to Texas to New Jersey to Buffalo. So we and North Carolina and Kansas, so we have a pretty broad swath of the nation. In terms of the randomization, we did it in waves because of the time it took to recruitment. We didn't want to wait till we recruited all 40 practices to do that. So we had 3 waves of randomization. Once we got 18, we compared 9 to 9. And then after the first randomization, between the first wave and the second wave, we had to modify how we did the randomization. The reason is that we randomized by practice and not by organization. But then there was this one group where they shared all their quality information data. They were meeting, they were talking about things. So basically, if 2 practices got facilitation, all the information from the facilitation was going to go to the other 2 practices. So we had to re-randomize them according to the organization. There was one organization where there were 2 practices within the organization, but they never spoke to each other, so we left them in separate groups. But waves 2 and 3, we did randomize at the organization level. And I honestly don't know if it's important to move our randomization up from practice level to organization level. The advantage of that is you prevent contamination. The disadvantage of that is you're changing your number that you're dealing with. As it is, 20 those 40 practices would be down to about 26 if we did it by organization. So I don't know the answer to that question, but the problem of the organization level and contamination is important. Why do we randomize clusters instead of individuals? Well, basically the intervention is at the team level. Are we making a change in the population? And also, if you randomize at the individual level, I talked about the contamination at the organization level. It becomes worse if it's from the practice. Also, it would drive a practicing clinician nuts if, oh, I have to deal with this person this way, but another person differently. And it's very feasible. You know, I mentioned the economic considerations. I started to get into this, common issues with the cluster randomized trials, and these are practical clinical trials. And the NIH is very interested in figuring out how to do pragmatic clinical trials for some of the economic reasons I described before, like the Women's Health Initiative, National Child Initiative. These are all $100 to $150 million studies with a small number of patients. If we can get lots of patients at a much lower cost, my grant is $2.5 million. So it's $28,000 that we're following for $2.5 million as opposed to $3,000 for $100 million. So from a return on investment point of view, we think we're a bargain. The number of groups is small, and when you do it by groups, the heterogeneity is of a larger size. Simple or stratified randomization can result in study arms that are unbalanced, and stratification can only deal with a limited number of variables. So we had to work on randomization, so that, well, so we're randomizing at the practice level. The question is, how do we know these practices are the same? So we used a number of variables, and we used baseline practice performance and characteristics, and we were able to balance multiple criteria, even with small practices. The fact that we had historical data allowed us to tailor the academic detailing for each site. We can focus on the diagnosis and the screening. So the procedure for the covariate, so we actually published this, covariate constrained randomization. And what was really sort of neat, the NIH has a collaboratory function where they're trying to learn how to do pragmatic clinical trials out of Duke, and they came to the same conclusion that the best way to create balanced groups in a cluster randomized trial was through constrained covariate randomization. So you have to have baseline data available, which is one of the advantages. The beauty of DARTNet is it not only puts you access to the database, once you tap into the database, you have the full electronic record from the beginning. So you have a longitudinal data set backwards, and you have a prospective data set moving forwards. You can look at all possible randomizations in the groups generated. You can create a balance criterion, which is using the standard variables. And you can allow for maximum allowable difference. And the single randomization, so that you can figure out all the different kinds of randomizations and find the type that works best. Next slide. So here were some of the variables we used in chronic kidney disease. So we used structural and socio-demographic data, which was obtained from a practice survey. So it wasn't all from EMR. We did do a practice survey on number of clinicians, et cetera. And then we used clinical data of the eligible patients. And then we aggregated the practice level. So here are the elements we used. The number of FTE clinicians. Oh, go back one. You're too quick. Yeah, no, back. That one, yeah. So here's where we showed the optimal set was very much alike, but you can see what they are. Clinicians, race and ethnicity, Medicaid and uninsured, so was our socioeconomic surrogate. The diagnosis of diabetes, the level of diabetes with a stage 4 CKD, and their control of blood pressure and where they were at baseline in terms of their kidney function and pressure. And you can see the groups came out very close. Next slide. And so the covariate constrained randomization procedures are useful for achieving balance, and the preliminary data on key variables is necessary, so it's good to have that in advance. Stratification can be incorporated, and you can weight them. So although every study is different, and there's the reference that we have for the study. Wilson, you going to take over? Or
thanks. Can you hear me? Am I back on?
Yes,
you are.
All right, thanks. So the CKD project really blurred the QI and research activities, and we'll go back over that constrained variable randomization as we use it again to create temporal controls and with some other models. But basically all the interventions here were based on AHR data. Clinicians were entirely focused on delivering care, and we're able to get some other kinds of outcomes out of it. Obviously, Chet talked about the intermediate outcomes, change in EGFR. We are hopeful we can track ESRD in death. Don't know that we'll have enough cases in the short time frame, but we'll try to add to that. But on top of that, we can also look at adverse effects. So as you start to add ACE and ARBs, we can actually find people who develop hyperkalemia because of the treatment. We can look as you add antihypertensives to patients that may not be hypertensive at the time, but you're adding them for other reasons. You may create more falls. And you can actually look at the rates of hip, forearm, and clavicle fractures like that come through as long bone fractures and see whether or not you've changed that because you have all these diagnostic information. You also can look for acute renal injury as a new term. So there's the ability to look at adverse outcomes as well as just the positive outcomes, which are hard to collect in a standard kind of approach. So it's a nice example of how we really, for the clinician side, just quality improvement, but we got an incredible array of outcomes for a very interesting price. But now I'm going to move on to some other ideas. One of the things that really not every study and all the data you want can be done simply from EMR data. So you really need to start using other PBRN techniques. But we want to match that up to the EHR data and not require repeat data collection for information we already have. So things you might be of interest is patient and clinician decision making, why I did what I did. Maybe you need patient-reported outcomes. I'm studying depression, I'm studying asthma. It may not be in the EMR as well as you'd like. And you may need to enhance clinical data collection because you're actually, the clinicians themselves aren't getting the data as often as you would like for specific activity. So moving beyond just the passive approach to data collection, well, we'll talk about some other approaches we've used in other studies. And one of those kind of classic approaches to get to clinician and patient data, came out of the Ambulatory Sentinel Practice Network in the 80s, and we kind of call it a CARD study. I think most people in the PBRN world are familiar with various approaches for card studies. So this was an AHRQ task order actually done a little while ago that we'll talk about how we incorporated it into our electronic activity. So the underlying study was to look at whether we can improve and get people to more guideline-concordant care for community-acquired methicillin-resistant staph. And we were interested in why people chose to treat people the way they did when they knew that MRSA was a potential problem within that treatment group. So the first piece of this project, this practices developed their own interventional approaches and things. We used EHR data. We used data from clinicians directly. We had to use some manual chart audit from activities. We won't get into that one for this talk today, but it was very easy to do. It could all be done centrally by a single person. And we got patient outcomes, and we actually, every patient in the intervention side was called 2 weeks after they were identified in the EHR to figure out if they'd had any out-of-system visits, ED visits, or hospitalizations. And all of this information from all these different sources was all linked through temporary linking numbers such that the EHR data could be included with all of this other information in the analytics. As far as we can tell from our chart audits, we were able to track 100% of soft tissue skin infections. We had about 3,000 cases in the observational control period and about 1,500 cases in the intervention period, which is only 8 months. Antibiotics for MRSA increased. We don't really need the outcomes there. It wasn't really important. But one of the things we want to talk about was really we were interested in why people chose to follow guidelines and why people chose not to follow guidelines. And we did that by creating a model whereby we actually developed a quick email system and a query system into clinicians that was done internally behind their own firewall, so we didn't have to worry about HIPAA out in the external environment for clinical data. And we used that to collect clinician data. So basically, we came up with 16 different clinical scenarios that we could understand from the existing EHR data. So we didn't have just one set of questions. The questions were tailored to the underlying clinical condition. And then we got a nightly data feed without identifying patients. We got a nightly data feed of which clinicians had seen somebody yesterday that fit one of these clinical scenarios, and then certain other clinicians got asked questions about them and certain ones didn't to try to check for Hawthorne effect. And so every night when we got that data feed, the next morning the clinician would come in and they would get a little pop-up email that said, you saw Timmy Jones yesterday and you decided you were in this group. Why did you do this? Why did you do that? And we had a nice little chart on it. We got about 75% response rate back from clinicians. And we actually know who we didn't get response rates back, so we actually can compare the differences between responders and non-responders at the patient level, which is very hard to do at a regular card study where you really never know whether you got a good response rate or not. And so this was a very kind of interesting way to add in a classic PBRN approach in an automated fashion where we actually understood the denominator, we knew what numerator we got, and we could actually tailor the card study specifically to the clinical situation. We also call all patients back. This is a different activity, but I don't call this too much. You could do claims data for this. The claims data could take up to 90 days to come back, and we really wanted to get feedback much faster. The practice took this on, and we understood exactly where people ended up with complications. So it was a really pretty complete data. So let me take this one. So the other action you may have is that was capturing information from clinicians, and we used the EHR data to determine what data we wanted and how to put it in there. At times, you also want to capture data from patients. We can do that sometimes through classic card studies as well, or in this case, you might want to actually include that data into the clinical care. So we'll talk about another project that was, I think, also AHRQ-funded. And in this one, we actually set up a system to actually collect, and we actually have a major system that's connected in to our EHR-based system, such that we can find patients, we can send out letters from the practice or other activities to invite patients into the study or into the clinical activity. Patients can do it from their office, they can do it from home. It's a multiple different approach to dealing with it. From the AHR data, we can figure out which patients should be included for the patient-reported outcomes. You can actually collect the data outside of the practice if you want, so you're not impacting the practice and making them have to do a whole lot of work. And then that patient-reported outcome data is connected back to the EHR data. And in this case, we'll show the one I'll show, it was used clinically as well as used as part of the research activity. So this was a study that the Children's Hospital of Philadelphia conducted with us, and it was really looking at patient portals from Meaningful Use 3. But what they wanted to do is see whether we could incorporate better information about asthma, connect it into what people were doing, and then provide information back to clinicians about how they might improve the care for these kids with asthma. Like you said, EHR data used to select patients, online system was used to collect it, and all data collected at the end. I'm going to move through it pretty quickly. This was not a huge study. I think we had about 200 patients, 250 patients who used the online system. But then the system analyzed the data. You got educational feedback if you wanted it at the parent or kid level. And if, in fact, that parent put in data that indicated this child was in poor control with their asthma, actually the clinician got immediate feedback to them to say you might want to consider contacting your office, may want to consider contacting and having a conversation with this parent or this child. If they were in good control, the information showed up the next time. We didn't send the information immediately back to them. We actually saved it and sent it based on the next appointment because we could see the appointments that were coming in, which is when clinicians said they wanted it. They didn't want to deal with something that wasn't important clinically to them until they have her seeing the patient again. So we were able to tailor all of that to what clinicians wanted. Here's kind of some slides of what the system looked like. And the report was fairly busy, but that's what the Children's Hospital wanted. And the clinicians enjoyed it quite a lot. And a number of the practices after the project was done had stayed on this system for up to a year afterward. Eventually it becomes hard to continue to support it without any other support. But the practices really did enjoy this project. And all of that data, as I said, got collected and it got added back to the EHR data. So you had drug information, you had the age of the child, you had all the comorbidities and everything else all together for analysis for the study itself. And won't go into all the different arms. It's not really the critical part here today. So with these kind of techniques, we can collect data at the office using tablets. We can collect it from home. We can collect it from phones. You can incorporate it. And you really broaden out your approaches to how you start thinking about adding PBRN data and the kind of projects you can do, all guided through initially having good patient cohort data. All right. The next area I'm going to talk about is one that we're really just getting started in. And that is
Dr. Pace?
Yes.
If I could just interrupt with a couple of questions before we go on. So in the beginning you talked about one of the strategies is for both looking at the breadth of data but not at the exclusion of understanding how that information is informing and being fed back to the point of care. And so the first example that Dr. Fox presented in the CKD study, if Dr. Fox could go and share with us, was the information provided periodically back to those clinicians, or was the guidance and the feedback given holistically at the end of the study? And if so, in what format was the information conveyed? Dr. Fox?
Hold on. Can you hear me now?
Yes.
Okay. Let's take those questions one by one. And the first question is, all the practices, both intervention and control, had the daily point of care report to them. In terms of how they were doing globally, that was fed back to the intervention practices quarterly. And it was fed back in two ways. Now, I say quarterly, and I'm putting finger quotes around that, because we did have some trouble creating and merging the data. So sometimes it was every 6 months instead of every 3 months. But I think we now have it down, the database system down, so that we will have it regularly on an every 3-month thing. And that was fed back in 2 ways. For each of the interventions, for each of the elements, there were basically 13 elements that we were doing. There were 7 outcome measures we were measuring and 6 process measures. The intermediate outcomes were control of blood pressure, control of blood sugar, control of cholesterol, the use of ACE and ARB if they had stage 3 CKD, the discontinuation of non-steroidals, and the referral to the nephrologist. I think I'm missing one. The referral to the nephrologist if they hit CKD stage 4. Those are all evidence-based out of the kidney disease guidelines. On the process side, we were measuring, did they get a hemoglobin A1C each year? Did they get an LDL each year? If they didn't have a diagnosis of CKD, if they had one abnormal eGFR or urine albumin creatinine ratio, did they follow up? So those were the kinds of measures. So each one of those, we gave them 2 kinds of reports. The first was a longitudinal report on how they did each quarter from beginning to end. And if you give me a couple minutes in between, I'll try and pull up those reports and show my screen. And the second was on each of the measures, they were giving a benchmarking report. So each of the practices was a bar on how well they were doing compared to all the other intervention practices. They were in red, all the other practices were in blue. So for example, for control of hemoglobin A1C, they might be in the middle, they might be at the upper end, they might be in the lower end. So they saw A, how they were doing longitudinally on each individual measure, and B, how they were doing compared to the other practices. Does that answer your question?
Yeah, thank you. So, but for those who were not performing as well as they wanted to, did your study provide some assistance on changes they might make in order to improve their performance?
That was actually, on the intervention side, that was the point of the study.
But how did that take place?
We had, as part of the virtual practice facilitation, the practice facilitator met together. There were 2 interventions that we had at the practice level. We had a practice facilitation and we had an academic mentoring program. On the practice facilitation, the practice facilitator at least once a month, if not more, contacted the site coordinator to help them select what PDSA cycles they were going to do and help with any workflow or other issues. In addition to that, once a month, one of the academic mentors met with the lead clinician and the practice facilitator and anyone else from their team to talk about their thoughts about their guidelines, the evidence, what they're going to do, and the data was reviewed with them at that time. Now, the academic mentoring was actually pretty interesting because there were 2 of us. There was myself, who was a family physician, and there was also Dr. Joseph Vassalotti, who's the Chief Medical Officer of the National Kidney Foundation. And we divided them so the practices, if they had more process questions or health IT questions, which I was stronger in, I spoke with the practice. If they had more specific nephrology specialty questions, he worked with them. But we divided up the practices we worked with that way.
And so the way the intervention was designed, there was interaction between the you and the researchers and the actual clinicians, in terms of the clinicians could highlight to you what particular areas they thought your counsel to improve upon.
That's correct.
And so in that way, they're somewhat driving how you're going to apply your resources.
Exactly.
Okay, thank you.
In fact, let me give you an example on that, because what happened was, as we started to share the data, and this is probably one of the key evidence things that we learned in the study, is everyone said, it's great that you gave me this report on how I'm doing or not doing. But unless I know who they are, you told me 30% of my patients blood pressure is not under control, but I need to know who they are. Every one of them asked for a population registry tool or a population health tool, that the point-of-care decision support wasn't enough without it. And we're actually working on and piloting a population health tool to go on top of it. And we did that in one practice. And the one practice that we've done it in, the rate of diagnosis of CKD has gone up over 90%. So I don't know if that's related to the tool or whether they're an early adopter practice, but it's a type of tool where you can actually query the spreadsheet and just ask the question 1 or 0. Have they been diagnosed with CKD? Is their hemoglobin A1C under control? And create basically an Excel spreadsheet of who it is. And we're actually modifying that population health tool that they can actually use it as a mail merge to talk to their patients.
And so what you found in the additional notifications that you generated through your intervention, not only did you not find your participants indicating that they have alert fatigue, but they articulated and helped you compose other types of alerts, the population health alert that had provided greater specificity so they could provide better monitoring and care for their patients. Would that be an accurate characterization?
Yeah, that's the accurate characterization. The decision support tool we use, we don't use pop-ups. The point-of-care support tool, and I'll try and pull that up so we can look at it also, and I'll let you know when I can pull that up. That gives a patient profile. So the patient's in front of them, and it's not about chronic kidney disease, it's about the patient. So Mrs. Smith may need hemoglobin A1C in a mammogram and something for CKD, but Mr. Jones may need something for CKD and hypertension. So the reports are individualized so that they're useful at the point of care, and they're not disease-based, they're more patient-based.
Great, thank you very much. So I'm sorry to have, but that type of clarification in the, for our general audience, I think is quite helpful. Thank you very much, Dr. Fox.
Yeah, I'm going to pull some of those graphs up if I can, and then I can share my screen and show it.
Yeah, it's a very, the point of care, and it's an interesting, we could have a whole discussion about trying to deliver clinical decision support for clinicians in the different ways, and you know, often people come back to the way we're doing it and saying, gosh, that's old-fashioned and everything, because we still use paper in most of the sites, but the amount of data we're putting out there for people and the synthesis that goes on is just very, very high level. All right, so great. So we'll move on to one last, I think, well, there's a couple last things here quickly, and then we can go on to all kinds of other questions, hopefully. One of the things that also comes up when you're trying to do practice-based research is often we're using kind of quasi-experimental designs. So I'll use an example of another major art project going on right now is that there are the R18s working on the Million Heart campaign and how to put the core evidence into practice and get people to change their care. And those are very large grants, I think, as people know, and trying to impact as many as 250 practices at each of the 7 sites. And a lot of them are not, given the time frame and the short control, they're not really randomized trials with practices that aren't getting the intervention for a lot of the sites. They want everybody to actually get this project. So then the question becomes, when you're done, did you actually impact this, or was this just a temporal function going on across the entire country? And so we're using several of those, or 2 of those sites now as well, and several are proposed that are using existing data that we have in our other activities to help develop these temporal controls. And even in Chet's practice, one of the things in Chet's study, one of the things we quickly recognized was we actually intervened in both sides. I mean, everybody got this point of care tool, and everybody got all of this information for each patient walking through the door. And so the question was, you know, we are probably going to see differences, but also what was the difference to just the CDS? And we don't know that without going back to some other controls like this. At least it gives you a better idea. But you can't just go pick any sites out of there. You really need to figure out ways to find your practices. So just for some information, we happen to have data now currently on about 800 primary care sites around the country. Soon I think it'll double, that we get every quarter, and we run a series of quality reports against that. It's a whole other project, but that information has all the data needed for many different projects, including the Million Hearts campaign and Chet's project, to actually characterize how those practices are doing. And in fact, all of those reports are part of our quality reports for those sites. So you have now a huge repository of practices that are serving in the sense of the temporal control potentially, but you need to figure out which ones you want to use and how you would do that. So there's really two different approaches that you can do. One is to use the covariate constrained randomization approach Chet talked about, but do it in reverse. And the other is a more classic propensity scoring approach. So I'll walk through those quickly so people that might be interested in this kind of a concept. So in the covariate constrained model, you use a similar balance equation, which is a sum of least squares activity, but you do that on your intervention practices that you're trying to control for, and you now have a population score. You add it across it, and you have a population score for that set of practices against on the variables that you want to include. In this case, you want to include your baseline variables because you're interested in making sure that baseline, if possible, your controls were doing pretty much the same at the population level around recognition of CKD or recognition use of aspirin for atherosclerotic disease, whatever your outcomes are. You now have a larger set of practices. In this case, let's say we have 200 practices that look similar in overall constructs. You then can go in and generate thousands, literally thousands and thousands of subsets of these practices using kind of Monte Carlo techniques. And then you can run the same equation against them. And typically what you'll come up with is maybe 200 or 300 different sets of practices that are very similar using this covariate constrained model at their population level. Then you randomly select one of those, let's say, 100 different sets of practices that you want to use for your temporal control. Or if you want to be even more size, you could randomly select 2 or 3 of them, and you see how they change. And then what you end up doing is now you have this data going forward 3 years, let's say, and you're doing a difference of differences analysis, but you have a very different approach without having to go and find all these practices in advance. There's lots of nuances to this, and we could talk about it if people want to ask more questions, but it's an interesting approach to actually add some better data around temporal trends within your less than pure experimental design sometimes. A different variation on this, which is very similar but just has slight variations, and I can't tell you right now, we've not done this enough to say one of these has any advantages over the other. But remember what I said, what we did in the covariate constraint is we took a population, so we didn't really look at any individual practice and say, these practices, these 8 practices look like those 8 practices. We just said that these 40 practices overall as a population look like those 40 practices. If you have concerns about that, you could take this down into a propensity scoring approach. And what you would do there is that you would use the very same set. You could start with the same variables. You might decide even that you want to look at different approaches to propensity scoring. We don't need to totally get into that, but there's a directed acyclical graph approach, which typically ends up with a lot less variables that you control for, and there's the classic high variable approach. And so you can even get down to the idea using a propensity model about why you might leave in variables or not. You create the similar equations, and then what you do a little differently, you go in and under your interventional sites, if there are any outliers, you throw them out. You get rid of outliers. You then create a population of scores, which then have a range, and you create groupings, typically quintiles, but you can change your size. You could do this in quartiles. You could do it if you had a lot of sites. You might do it at 10% levels. You create a range of these scores. You do that same thing for your temporal controls, and then you select within that quintile. You say, all right, my scores for this quintile range from 1.2 to 1.28 or 1.3. I will go find a random set of practices that have those same scores, 8 practices, let's say, or 10, and you do it quintile by quintile. So you don't match practice to practice. You match quintile. You match group to group. but you actually are doing this at a more granular level within the practice as opposed to the entire population. So, you know, there are some differences here. The propensity does create this more granular level, but generally to do propensity matching, you need a lot more control units to do it. Because you're trying to prepare on that. Now, in some of our data sets where we have 3 or 4 or 5 or 600 practices to use in the control set, that's not a problem. If you only have 60 practices that you could potentially use as controls and you want to control for 30 practices in your intervention, you probably would have a hard time doing that on propensity models. So those are some of the difference. And there's all kinds of variations in here that we could talk about down the line. But it's a very interesting approach to how you can start bringing a little more experimental design into our quasi-experimental approaches within that. And as I said, 2 of the 7 R18s are going to be doing this using DARTNet data for it. Another thing that PBRNs are working on a lot right now is how do we remain valuable and viable and interacting in the ACO world as people are starting to get into accountable cares. And so just one project to kind of demonstrate some of the ways that decision and data have been able to do that with a project that it is actually an industry-funded project, but out of the NRN. And the project was focused on how to improve immunization rates for adults, and we were able to find one of our specialty ACOs, multi-specialty ACOs we've worked with for a long time, that actually was not meeting this goal. We actually went around and said, you know, who's interested in this? And they said, you know, we're not meeting this for Medicare. We actually need help on how we get there. And you can see it's a moderate-sized system, about 40,000 Medicare patients, 250,000 total patients. And the long story short was that we actually got this grant. We actually have funds directly going to them, so they actually have resources now to help them understand how to change. And we're doing many of the things that Chet did, but we really went through their clinical decision support. We talked to them about standing orders. We talked to them about their flow of activities and areas where they got pushback. We talked to them about, you know, it doesn't have to be just primary care that delivers an immunization. Why aren't your cardiologists and nephrologists delivering this immunization when they see people? Why worry about where it gets done? Just get it done. And we worked, and we also have developed an approach to feedback, which is we call a missed opportunity or gap analysis report, which clinicians variably like or hate. I don't know, but the point is you have the opportunity to give this intervention. Could be anything. Could be ordering a test or whatever. These set of patients needed it in the last 3 months. It was under your control with that patient to either offer it and have it refused or offer it and have it accepted. And here's how many people you offered it to, and here's how many people you missed. And this is a whole micro team level now because the nurse could offer it. It could be done as a standing order. The clinician could do it. You could give the information from the front desk to the patient. So we really worked with them on a micro team level to say, how do you change what you're doing? And that data comes back quarterly now from them, and they can actually change their outcomes very quickly because it's much more under their control than a population report for people I haven't even seen in 15 months or something. So that's a model of how, so that ACO is very excited about all the different activities from our perspective of a PBRN, using data, using decision support, and bringing dollars to bear to help them in the quality improvement side and us on the research side. The CDS we have in place, they've demonstrated that our current CDS is virtually 100% accurate in picking up the right vaccination rates for these patients, mostly elderly, but not all. And their current EMR-based CDS, which they also have, is only about 80% accurate. And about 80% accuracy, when you're being told to do something, most clinicians will ignore, I'll tell you. We talked about the micro teams, and we were unsuccessful at getting specialists to implement this so far, but we're still working on them. We also are tracking all immunizations. Again, we're looking to make sure that we don't have a negative impact, and because we're focused on this set of immunizations, do we in fact see less of other immunizations being administered than we had before. So we also can look for the marshmallow effect of pushing on one area of the practice and something else gets worse. So I think we've covered some very broad perspectives of how having access to data and various systems around it can be integrated into really classic PBRN approaches, everything from more observational work to enhancing clinical data to really doing best practices in PBR and interventional trials. So it's been a fun adventure. It's not easy. I can tell you that. I don't know if I put it in here. No. I can tell you that EHR data is tough to work with. It's not research quality all the time, and you got to figure out how to add information around it without a doubt. And as you know, a lot of organizations are still questioning its use, particularly, let's say, FDA, who won't use it at all. But from the PBRN perspective and quality improvement, it really is a lot of fun. So I'll stop and let's have some time for questions.
I can jump in on a couple of those points, and then I want to share my screen because I have some examples. Yes, this is not for the faint of heart, and Wilson and I are presently in the process of writing up a paper called Promises and Pitfalls of Using Electronic Health Record Data for Practice Improvement Research. So anyway, there are lots of pitfalls that we ran into. This is not for the faint of heart, but the bonus of having that much data on that many patients and some of the data that we're getting out is actually pretty impressive. We did a sub-study on my CKD, and this is really hot off the presses, and we just analyzed, we compared people with disability on how they responded with CKD progression versus people without disability. We got a clinician who was disabled who got a disability supplement on that, and we found that people with disabilities, and we define disability fairly simply, anyone with Medicare under the age of 65 we assumed was disabled. And we compared those in the 18 to 85 population, those without, and the bottom line, not totally surprising, is that while there was a straightforward linear progression of people with disabilities, and the progression was worse with disabilities, and they started in worse shape even when we started at time 0. The other things that I wanted to talk about was that, can we show my screen? Can I share my screen? Can someone give me the?
Yes, it should be popping up right now.
Okay, I'm going to make this larger. We can't fully see this. Well, now I'm going to make it larger. But here's, you asked what the decision support was. Here's an example of what it looks like. So there's the diagnosis, the meds, the labs, other things. And then there's this section right here called action items. And this will have it across multiple diseases, and this comes out daily to the practices. A lot of practices have their individual workflows, but this also helps with the team approach. A lot of it uses the MOA goes in, looks at the action items to be documented. So where it says order hemoglobin A1C, they will go ahead and put a requisition in the chart. Or if it's order mammogram, they'll go ahead and put a requisition in the chart. Or they'll highlight the things for the doctor to do, and they'll create the order in the thing. And you asked about what the reports look like. Here's an example of the reports on how they were benchmarked. So the blue was the practice, the rest was the others, and so for each of the measures, they can see how they're doing. So I think one of the reasons practices didn't get upset, because what you see here is fairly common. No one was perfect on everything. So here they are in terms of control of blood pressure. They're doing great. But with the use of ACE and ARBs, they're at the lower end of the scale. So when the practice looked at its profile, there were often things that they were stronger in and not so strong in. And then they use that to discuss. The other thing about the quarterly feedback, the first thing that we always did, because everyone knows that every doctor is perfect and doing nothing wrong and it's all problems with the data, we make sure that we in the practice agreed that the data was legitimate before we went on to discuss discuss things like how they were doing. And then the quarterly reports would, here's just one report, this is just their baseline data, but each quarter there'd be another bar along those on how they saw the data. Rebecca, does that give you an example of the reports and stuff?
I think that's quite illustrative, and the point that you all made separately, it seems like, would you agree that quarterly feedback once you get an intervention going is a natural and a welcome means by which they can actually reflect and work with practice facilitators or others to improve overall quality of whatever's being measured?
I think that's a great point. In fact, what happened was we had trouble with the database. In fact, we found out that the person who was doing our database did it in a sort of individual way. That person left, and we had to rewrite the database from scratch. So that gave us a 6-month delay. And the practices didn't want to talk to us if we didn't have data. They said, why am I meeting with you if you can't review my data with me? So the data, they're very data-driven and helps them with doing that. The other thing that they requested was we gave the reports as a team, but individual practices said, could you give me the individual data? So it's not just me that I have the data on each of the clinicians. So we're in the process of giving individual clinician feedback.
Thank you.
Your point that the doctors are very data-driven, the first thing is for them to believe that the data is real. Once they believe the data is real, they find it very useful.
Yep. Okay, great.
I can stop sharing my screen now. Someone can take over.
Erica's going to pull up some slides now.
So if there's anyone else out there who wants to pose a question, please do. While we're waiting for folks to pose questions, I'll go back to Dr. Pace. So you talked about quintessential PBRN strategies for research, and many of the folks who are part of this are quite familiar with PBRNs, but would you care to just take a few moments to elaborate what it means to be a PBRN and some of the traditional qualities of the qualitative and quantitative research perspectives that PBRNs represent?
Sure. So I think that most of us know that PBRNs are mostly about relationships, and it's about developing a set of organizations, practices, and clinicians, depending on what level you work at, that are interested in asking and answering questions, but also interested in some camaraderie and some other activities and discussions and other things. So it's very much a give and take kind of an environment as opposed to simply a data mining environment. And out of that means, for instance, as you can tell from Chet's project, there was a lot of give and take, and there's a lot of conversations. And in fact, one of those sites came up with some new decision support techniques and changed some of the decision supports by what they were recognizing and asking for. So it was very much that kind of activity. And within that, the other thing we're interested in is not only the context of what the practice is living in, and so and believe me, over a 5-year study, you end up with all kinds of things. Practices get bought, they get sold, they change EHRs. The new organization that purchased them doesn't want them in research. It's a really tough kind of environment to deal with and those kind of things. But so all that contextual information needs to be added around your outcomes, and then as well as the contextual information around such as how they make decisions. So we didn't get into all of the qualitative side, but within most of these studies, there's a very large qualitative side that goes in and tracks. So, for instance, the TRANSLATE rubric that Chet talked about, we actually track that on a regular basis of how each practice is doing in each of those domains and how well they are positioned. And they can go up and down over time based on what's going on in the practice about how ready they really are to help make that next step and that next improvement process. So all of those things are kind of things we typically think of in PBRN world pretty routinely. You're seeing them in other places. I'm not saying we have rights to all that by any means, but it kind of is our history of where we come from. And then, as we talked about before, I think data from the point of care and data that asks about why, from a patient perspective or a clinician perspective, why you did something, as opposed to just saying you didn't do it compared to a guideline. But what we found, for instance, for the MRSA study, when people said, why didn't you do this or that? Why didn't you get a culture? Okay, why didn't you get a culture? And they say, I've cultured this person 3 times before. It's always MRSA. I'm expecting it to be MRSA this time, and it won't add anything to my decision making. I just have to treat it that way. And oh, by the way, the staff, these are 2 community organizations, one in Texas and one in North Carolina. And of the cultures that came back positive for staff, 65% were MRSA in the community. So they're definitely dealing with it. So those are some of the ideas of how we think about from the PBRN side, getting data right from clinicians, including the decision process, as opposed to just saying it was right or wrong. What are good reasons for deviating, and not saying that that's a bad outcome in and of itself, but actually looking at how patients do. And we actually got that data from a lot of these projects as well. A few things.
Well, thank you. And any other questions?
Everybody's all ready to go out and do their covariate constrained randomizations and propensity scoring for their temporal controls?
So we do have a recording of the TRANSLATE model being put in place and discussed further that Dr. Fox mentioned early on in this presentation, and we can include a slide when this particular webinar is made available of how to link to that presentation, both in webcast and in PDF file. Before we close,
about that, we did find, it's just preliminary data, but we are finding level of engagement on the various sides of Translate did translate to improved care. And we not only found that in this project, we're finding it in a cancer screening project we're doing. Just some early data along those lines.
Okay,
so you can add that.
Okay, thank you. And so, getting back to the one of the original impetus to have this particular webinar was with respect to the use of big data. And I was wondering if you, so we've talked a lot about DARTNet, but if Dr. Pace and Dr. Fox, if you would, so DARTNet has a variety of data from various EHR vendors, et cetera, and from across the nation. But when you talk about big data, what's your vision for the future, or, with respect to, will it be consolidated data in one location, or federated data across multiple different sources? Where do you see us going? What's going to be big data?
Yeah, well, first is, of course, from the true big data people like Google and things, we're still in the small scale, but we're not, we're still using SAS and other things, although we're about running out of the capabilities of that, and they can't do that anymore. But I don't think, and just, DARTNet is just because we've had 8 years of experience of trying it. So the only reason we're here as a DARTNet is really to say, these are things that are possible, and here's things you should be thinking about with however you get your EHR data. It's not related to us specifically. It's just that the concepts are what we're trying to highlight here. I do think we're going to end up more and more. This data is getting too large to think that this is going to be a central repository, despite what some people say. We're going to really more and more be federated, or there will be subsets of data used for specific activities that can be that can be centralized. hopefully we will continue to see an improvement in the underlying structure of data within EHRs. Everybody says they meet ONC standards, yet when we get into them, we rarely find they really do. Also, hopefully we will continue to find more user-friendly approaches at the front end that clinicians can actually capture information that's important beyond just labs and vital signs that we can capture and actually use for analyses. And we're starting to see more of that, but it's still not as universal as you'd like. So once you start getting into more behavioral areas and things, this becomes a lot more work to try to figure out what's really going on. So those are some. We hope that those things will be moving forward. There will be, I'm sure that there's already consolidation in the industry, and I can tell you that from interacting with many vendors that the vendors have very different attitudes about this. Some of them are very interested in trying to how you improve care, and some of them are very protective of their data and make it very difficult to get to, even for the practice themselves. And so that's another concern I have going forward is that in fact we may see some backsliding as more and more of these EHRs go into the cloud, and the vendor then controls access to the data, and the vendor doesn't want to really give you, they want to do the analytics and they want to give you reports, not patient-level data. And most of the stuff we've talked about here, much of it you can only really do with patient-level data. You can't do that with reports. So that's probably the concerning side of things. On the other side, hopefully we now see pretty much ubiquitous use of these tools in practices. So we really have the potential to use them for very interesting improvements.
A couple of things. I do think in terms of future vision, the move toward value-based care, I think, will be a driver about getting better clinical data out of the EMR, because it will be about producing quality, not just about producing volume. So these kinds of things are important. The key issue here is not about DARTNet. It's about being able to standardize the data, to being able to, one, find the data, and two, standardize the data. I knew nothing about health informatics before I got started in this, and three little letters kept popping up on every diagram called ETL, extraction, translation, and loading. And it sounds like a simple function, but it's not. But I think if we had a common way to extract, translate, and load, so that the people could talk to each other, that's how we're going to create the big data. Also, DARTNet's data is somewhat limited in that it's just clinical data that's already in the EMR. We really need much more a 360 view of data, where patient-reported outcomes could be added to that, in addition to hospital data and utilization data from the various payers, Medicare, Medicaid, commercial insurers. And we need to have that data looking at and in one place. So, for example, I may have a report that's very accurate from an EMR that Mrs. Smith needs a mammogram. But Mrs. Smith goes to her gynecologist every year and gets a mammogram. Well, if I have no idea from that, but that's in the insurance company's data set. So hopefully people will start to agree on at least a minimal common data set that say, one, we're going to find all the hemoglobin A1Cs in our chart, and we're going to put a code to it that anyone will be able to read that code no matter where it's from. In terms of other big data sources, PCORI has their CDRNs, Clinical Data Research Networks, that I think they're trying to do this to combine data from multiple sources. And then there's the HMO-RN that has data from multiple sources, but unfortunately, most of the HMO-RN data sources are just from Epic practices, so they're limited. So if we take the people that have big data and get them working together, that would be nice.
Well, I thank you. We'll give you the last word, Dr. Fox. And Christina, if you could just put the obtaining CME credit as our last slide for folks who are listening to this webinar. And I thank you all very much on this Friday afternoon for your very thorough presentation and spurring of ideas of how to use big data, how it's been used to date, some of the characteristics of PBRN research, the leading edge methodologies that are being applied in PBRNs, and we look forward to seeing how you inform the future and how we're informed by the drivers that are amongst us with respect to change in healthcare payment reform and general incentivization for quality improvement for many reasons. And with that, I think that's the end of today's webinar. Thank you.
Thank you.
Everybody.